Welcome to The Explainer. Today, we're talking about angina. And look, it's way more than just a bit of chest pain. You can think of it as a direct signal, kind of like an alarm bell from your heart, telling you something is seriously wrong. And understanding that signal, that's absolutely key.
So, at its very core, angina is a sign of something called myocardial ischemia. Now, that's just the fancy medical term for a really simple but pretty dangerous problem. The heart muscle just isn't getting enough oxygen-rich blood to do its job.
The easiest way to think about it is like a simple budget, an oxygen budget. You have oxygen supply, which is what the coronary arteries deliver, and you have oxygen demand, which is what the heart needs to work. When the demand goes up, say when you're exercising, but the supply can't keep up, that's when the heart sends out that pain signal. And that pain, that's angina.
So in this explainer, here's what we're going to do. We'll start with that core supply and demand problem. Then we'll explore the three main ways this whole balance gets thrown out of whack. We'll look at the specific treatments for each type, and we're going to finish up with a fascinating look at how emergency protocols have completely changed based on new evidence.
Okay, let's dive right in. You see, not all angina is created equal. Understanding the specific reason why that oxygen balance is off, what's actually going wrong inside the artery, is so important because it changes the entire game plan for treatment.
So you can really break it down into these three main types. First up, you've got exertional angina. That's the classic one. It's caused by a fixed blockage and usually pops up when you're exerting yourself. Then there's vasospastic angina, which is different. The artery itself just suddenly spasms shut, often for no clear reason. And finally, the most dangerous of all, unstable angina. This is a true medical emergency where a plaque breaks open and starts forming a clot.
So, how do we handle the most common type? Exertional angina. We're talking about something that affects roughly 90% of patients. This is that classic story. Someone's walking up a hill, their heart needs more oxygen, but a narrowed artery just can't deliver it. So, what do we do?
Well, the strategy is basically a three-pronged attack, using three major classes of drugs. You've got nitrates, beta blockers, and calcium channel blockers. Each one comes at that supply and demand problem from a slightly different but really clever angle. Let's break them down.
Okay, so nitroglycerin, that little pill you put under your tongue for quick relief, it works in a really fascinating way. You'd think it just forces the coronary artery open, right? But its main job is actually to dilate the veins all over your body. This means less blood comes back to the heart. Doctors call this decreasing the preload. Basically, the heart doesn't have to stretch as much or pump as hard. Its workload drops, its oxygen demand drops, and poof, the pain goes away. Pretty cool. Now, for preventing attacks from even starting, beta blockers are the star player. The best analogy is that they literally put the brakes on the heart. They slow down the heart rate, they reduce how forcefully it contracts, and all of that lowers its demand for oxygen. This means a person can do more, they can exercise longer before they ever hit that pain threshold. Okay, so we've talked about a fixed blockage, but what happens when the problem isn't a blockage at all, but the artery itself just freaking out and slamming shut? Well, that brings us to vasospastic angina. It's much rarer and it's weird. It often hits when people are just resting, sometimes even waking them up in the middle of the night. With this one, the goal is totally different. You have to relax the artery wall directly. That's why calcium channel blockers are the go-to choice for prevention. They stop that spasm from happening. For quick relief, you can still use nitroglycerin. But, and this is a big but, you have to address the triggers. Things like cigarette smoking and cocaine use are huge risk factors here.
And this leads us to a super important safety issue. A beta blocker, the hero drug for classic angina, isn't just useless here, it's actually dangerous. It can make things worse. The question is, why?
Well, the answer is in the push and pull of two different signals in our arteries. Think of it like a gas pedal and a brake. You've got alpha receptors that, when you hit them, cause the artery to constrict, to tighten up. And then you've got beta 2 receptors that, when you hit them, cause the artery to dilate, to relax. And right here, this is the whole reason it's so dangerous. When you give a beta blocker, you block that relaxing dilate signal from the beta 2 receptors. So what's left? You're left with the constrict signal from the alpha receptors totally unopposed, with nothing to fight it. For someone who's already prone to artery spasms, this can just pour gasoline on the fire and make the spasm way, way worse. All right, now we have to shift gears and talk about unstable angina. And let's be clear, this isn't just a symptom anymore. This is what's called an acute coronary syndrome. It is an absolute lights and sirens medical emergency. It's a sign that a heart attack could be just minutes away. So what's happening here isn't just a narrowing or a temporary spasm. This is an active, evolving disaster inside the artery. A piece of plaque has broken open, and now platelets are rushing to the scene, clumping together and forming a clot that's blocking blood flow. The pain is severe, it lasts a long time, more than 20 minutes, and it can happen at any moment.
For years, for decades, the immediate game plan in the ER was guided by a really simple, easy-to-remember acronym, MONA. Morphine, oxygen, nitroglycerin, and aspirin. If you came in with chest pain, you're probably going to get the MONA treatment.
But here's the thing about medicine. It's always learning, always evolving. And we figured out that what seems like simple common sense isn't always the best medicine. As a result, the M and the O in MONA, well, they're not quite the heroes we thought they were. So first, let's talk about oxygen. It seems so logical, right? The heart is starving for oxygen, so just give it more oxygen. But it turns out, for patients who already have normal oxygen levels in their blood, giving them extra can actually be harmful. It can create these nasty things called oxygen-free radicals, which can cause even more damage to the heart tissue. So, the bottom line is this. The guidelines have totally changed. Unless a patient's oxygen saturation actually drops below 90%, they don't get routine oxygen anymore. It's a huge shift in thinking.
Okay, so what about morphine? It's fantastic for pain and anxiety, and calming a patient down is good for the heart. But it comes with a pretty significant catch, especially for patients who are about to be rushed off for a procedure to open up that blocked artery. Here's the problem. Morphine slows everything down, including your gut. And that means it can seriously delay how quickly your body absorbs other life-saving oral medications, specifically anti-clotting drugs like clopidogrel. That's clopidogrel. Now, if that patient is on their way to get a stent put in, they need that drug working like yesterday. Any delay is a big, big deal. And that's why morphine is used so much more carefully now.
So when you look at the whole story, from these incredibly targeted drugs that restore the heart's oxygen balance, all the way to completely rethinking emergency acronyms that we took for granted, the treatment of angina is just a perfect example of how medicine is never standing still. It's always learning, always refining. And it leaves you with a final thought, doesn't it? What long-held medical truth is going to be the next one to evolve?